Hello, everyone. This is Farrell Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us for tonight's webinar on hepatorenal syndrome, known as HRS. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host community and patient-centered free educational programs. To learn more about us and our activities, please visit our website, liverhealthfoundations.org. Tonight's topic is hepatorenal syndrome, also, as I mentioned, known as HRS, which is a rare disease of liver and kidney with important consequences. HRS is a serious condition that affects kidneys function in individuals with advanced liver disease, which is cirrhosis most often. Studies suggest that up to 40% of people with end-stage liver disease will develop HRS. These people represent all ages and sexes. So in tonight's program, our expert, Dr. Robert Gish, will offer a detailed presentation about HRS, its causes, and any or all treatments. Tonight's program has been made possible by a grant from Mallinckrodt Pharmaceuticals. We thank Mallinckrodt for their support of our efforts. I would like now to introduce Ms. Holly Kirkpatrick, who is Acute Care Business Manager at Mallinckrodt. Thank you, Holly, for your support and for being here with us. We are ready to hear from you.
Thank you, Farah, for your leadership at the Liver Health Foundation, for your advocacy of liver diseases, and for the monthly educational webinars by renowned hepatologists and surgeons that increase our knowledge, our understanding, and compassion surrounding liver diseases. Mallinckrodt Pharmaceuticals is a global business consisting of multiple wholly owned subsidiaries that develop, manufacture, market, and distribute specialty pharmaceutical products and therapies. The company's specialty brands areas of focus include autoimmune and rare diseases in areas like hepatology, neurology, rheumatology, nephrology, pulmonology, ophthalmology, and oncology. Its specialty generics reportable segment includes specialty generic drugs and active pharmaceutical ingredients. We want to thank you, Dr. Gish, for your expertise on hepatorenal syndrome and for educating us so well tonight.
Thank you so much, Holly. We are appreciative of your help. And I also want to send my sincere thank you to Ms. Jennifer Trall, the Regional Business Manager, West for the Hospital Acute Care Team at Mallinckrodt Pharmaceuticals. Mallinckrodt has been supporting us for many years. And in fact, last weekend, we hosted a wonderful in-person walk in Orange County that was attended by many liver patients and their families and caregivers. Orange County hospitals, medical centers were there, and also we were sponsored by a great number of them, as well as the pharmaceutical companies. Mallinckrodt was one of the sponsors of the Walk for Your Liver, Orange County and Inland Empire. So thank you to all. It is now my pleasure to introduce tonight's speaker, Dr. Robert Gish, who has generously agreed to be the presenter in tonight's webinar. Dr. Gish is currently the medical director of the Hepatitis B Foundation in Doylestown, Pennsylvania. He is an adjunct professor of medicine at the University of Nevada, School of Medicine in Las Vegas. He serves as an adjunct professor of pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences at UCSD. He's also a clinical professor of medicine at Loma Linda University. Dr. Gish was a major early contributor to decipher methods for the detection of hepatitis B and C viruses and characterizing their epidemiology and clinical presentation in humans. He has published over 700 original articles, abstracts, and book chapters. He's currently a fellow of the American Association for the Study of Liver Disease, the AGA, and the American Society of Transplantation and American College of Physicians. He co-authored a public health policy for liver health in Vietnam, focusing on HBV, and is also assisting with the development of viral hepatitis healthcare policies in Western Africa, Uzbekistan, Georgia, Armenia, and the Philippines, among other countries. He is currently seeing patients both in person and via telemedicine at various clinics in San Diego, Folsom, El Dorado Hills, Santa Rosa, and Valley Springs. He's a staff physician at La Mistra, a federally qualified health center in San Diego. Dr. Gish, welcome to Ask Your Liver Doctors webinar series. Thank you for your continued support and participation. We are delighted to have you with us and sincerely thank you for your participation. We are ready now for your presentation.
Okay, and thanks a lot, Farah, for all that you do for our patients in California and throughout the country. Thanks for that great introduction. And I'm going to do a share screen and do from my side. Is that correct?
Yes.
Okay, let me get the slides up and go to full screen. There we go. So you should be able to see my blue screen here. So I'll be talking about this very sophisticated, complex subject. And the first part of this presentation is going to be patient-oriented. And then we're going to go to Q&A. And if we have time, I'm going to do a much deeper dive into the technical aspects of hepatorenal syndrome. But one of the most exciting things today is we have a treatment that's FDA approved for hepatorenal syndrome. This has been available, I think, for 4 years now. It's been available throughout the world, actually, for about 20 years, and it goes under the name of terlipressin. I'll talk about that in a little bit. But let's get into the general concepts behind HRS, or hepatorenal syndrome, or what's described really as kidney dysfunction in patients with cirrhosis. So there's 2 requirements for hepatorenal syndrome. One is cirrhosis, and the second one is ascites. You have to have these 2 precursors before you get into this complication of kidney dysfunction in patients with chronic liver disease. So cirrhosis, ascites sets the stage for kidney dysfunction or hepatorenal syndrome. I am serving as a consultant for Mallinckrodt and a speaker for terlipressin. But let's go back to the basics. What does the liver do every day? Well, it does about 200 different things, but let's make it simple. It's filter and it's a factory. So it filters toxins, it filters bacteria, and it's a factory. It makes a variety of different substances that we need each day to survive. Clotting factors, albumin are a couple of examples. Back to the filter, it filters out bilirubin. That's one of the important issues. It filters out ammonia, but the ammonia blood test is terrible. It's not good to assess liver function. It makes cholesterol. Cholesterol is actually a liver function test. And very importantly, when we're thinking about liver function, we think about different scores, something called the MELD score, something called CPT scores. So when you're talking to your providers as a patient and you want to talk about liver function, you need to be specific and make sure that your provider is not confusing liver enzymes with liver function. LFTs are an old, out-of-date term, which we don't use anymore. We use the term either liver enzymes or liver function. If we're thinking liver function, we're thinking bilirubin, albumin, and a clotting test. But later in liver dysfunction, in patients with cirrhosis, the creatinine, another blood test, is an excellent liver function test because the kidneys function is dependent on liver function. The kidneys in general are there to balance water retention, water excretion, electrolytes, sodium and potassium. The kidneys also are involved in acid-base balance, keeping your body between too acidic and too much base or too much bicarbonate. And the kidneys and the liver work in partnership here because the liver also balances bicarbonate or balances acids in the body. So the liver's in the belly and the right upper abdomen. The kidneys there's two of them in the back of the abdomen, one obviously behind the liver, one on the other side behind the spleen. The kidneys move this water into what are called ureters into the bladder, and then out and excrete that, what we do every day when we go to the bathroom, we urinate and move the water and electrolytes and toxins out of the body. The liver, we just have one, but as you know, in certain settings, we can take out part of the liver and give that to a different person. And it's very important when you're talking about liver disease is to stage the liver appropriately and think about stage from 0 to 4. Each patient needs to know their liver enzymes, their liver function, and the stage of their liver disease. We're now going to move to the next slide. And that slide is this slide that talks about how that liver is interacting, not just with the kidneys, but the liver interacts with the heart. When the liver goes into a state of dysfunction, the heart function starts going downhill. The liver interacts with the intestines. When the liver builds up cirrhosis, it builds up fluid below the liver into the abdomen called ascites. That causes congestion of the intestinal tract, decreases food absorption, decreases vitamin nutrient absorption, and can cause a variety of problems with either diarrhea or constipation. The liver interacts with the systemic circulation. So another liver function test is the blood pressure. In people with end-stage liver disease, the blood pressure always decreases, and patients with significant cirrhosis and ascites typically have low blood pressure, not high blood pressure. You rarely see hypertension in somebody with chronic liver disease, especially end-stage liver disease. When the liver gets sick and the intestines get sick, bacteria start moving across from the intestinal tract into the bloodstream. And it's these bacteria that can come back to the kidneys and cause kidney dysfunction. There's also differences in different hormones. What's called aldosterone, a renin-angiotensin system, hormone system, inflammatory systems, another hormone called ADH. And these are all interacting between the kidney, the liver, the blood circulation, and the brain to balance electrolytes, to balance blood pressure, changing sodium excretion, sodium retention into the body. Now, we tell people with cirrhosis to be on a low sodium diet because the liver and kidneys are hanging on to way too much sodium. And when you hang on to sodium, you hang on to water. When you hang on to sodium and water, you build up this fluid on the abdomen called ascites. There's also a dysfunction that takes place where the blood vessels, specifically the arteries that feed the kidney, undergo a type of spasm or vasoconstriction. And it's that vasoconstriction that hurts the kidneys and makes the kidneys not work well, not balance water and electrolytes. This medicine we'll talk about a little bit later, terlipressin, actually opens up those blood vessels. It changes the renal circulation and it rebalances the abnormal circulation in the intestinal tract. So you want to rebalance this, give better perfusion to the kidneys, better circulation to the intestinal tract, and increase how the kidneys are working. We call GFR. You might see that on your lab sheet, glomerular filtration rate, glomerular filtration rate. So there's a lot of balancing that's going on here. But once those kidneys start getting hurt, the blood pressure, the blood circulation, the kidney starts going down, the kidneys eventually get damaged. But early in this hepatorenal syndrome, when there's just a decreased perfusion of the kidneys, if you take those kidneys out and give those to another patient who's in kidney failure, the kidneys work normally. But after 2 to 4 to 6 weeks of this vasoconstriction, this abnormal perfusion, abnormal circulation to the kidneys, the kidneys do eventually get damaged, and very late, 2, 4, 6 weeks or more, the patient may not need just a liver transplant because of the cirrhosis, the ascites, the liver failure, but they may eventually need a kidney transplant. We can go into a little bit more detail about that and during the Q&A session. This kind of takes things out to a much bigger picture. You have arterial blood coming into the kidneys, circulates through the glomeruli, and that blood goes back through a vein, back circulating back to the heart. And it's this interaction, this balance that's super important to be thinking about, all of that blood being filtered through the kidneys. If the kidneys go into a vasoconstriction, where the arterial supply into that kidney on this next slide that you can see here, that means that the kidneys aren't going to be able to do their work. They're not going to be able to balance water and electrolytes accurately. A lot of conversation going on between the liver and the heart and the hormones and the kidneys. And that eventually leads to unhealthy kidneys into this HRS, hepatorenal syndrome. Back to a picture, keep it simple. You have to have cirrhosis, you have to have ascites, and then you have to have what we call another insult. It could be just progressive liver failure. But what about having an infection or GI bleed or getting hit with a medicine that can hurt the kidneys? That's not going to be true hepatorenal syndrome, but can be a form of what we call acute kidney injury. That acute kidney injury may be reversible. You treat the infection, the kidneys can recover. You treat the low blood pressure, the kidneys may be able to recover. You take away the medicine that's kidney toxic, the kidneys may be able to recover. But if you've ruled out those, you've taken those out of the equation, and there's progressive kidney dysfunction, a rise in the creatinine, and even a small change in this blood test of 0.3 milligrams per deciliter, and you don't have some other cause, it's time to be doing an intervention. The first intervention, take away the water pills. The second intervention, make sure the blood pressure is good. Third intervention is giving some volume boost with some albumin plus a liquid volume to increase that kidney perfusion. If those things are not working in 24 hours, it's time to take the second step. And that second step is this medicine called terlipressin. So terlipressin is a very important hormone-like medication that changes kidney perfusion, actually changes what's going on in the liver and in the intestinal tract as well. So this gives you a little bit more of a diagram about hepatorenal syndrome and this interaction between the liver, the hormonal system, what's going on in the splanchnic system, that's the blood vessels around the intestines, the blood vessels that are feeding the liver. What can happen with ascites is you can get way too much pressure inside the abdomen, and that can also compress the kidneys, compress the intestines, and decrease perfusion to the kidneys. If the patient has a bad heart from cirrhosis, that's called cirrhotic cardiomyopathy, that also can decrease renal perfusion. So every patient with cirrhosis and ascites should have a current cardiac heart echo in their chart. And I tend to order one new heart echo almost every day in clinics. I'm seeing some patient with new cirrhosis, and I want to know what's happening with their heart. I may be thinking to treat their ascites of putting in what we call a TIPS shunt. A TIPS shunt can actually help kidney perfusion as well. It's not really a first line or second line therapy for hepatorenal syndrome, but in some cases we do put in a TIPS and the kidneys start recovering. I want to repeat that we need to make sure there's no active infection in the belly, there's no active infection in the bloodstream. So if a patient comes in with ascites, every single patient, we need to take some fluid off with a needle. We need to send that fluid for culture in blood culture bottles. We need to assess that fluid for what's called a white count and a differential to see if there's bacterial infection inside the abdominal fluid. That's another way to help save those kidneys and turn around kidney dysfunction. So this just gives you a diagram about hepatorenal syndrome. When people have hepatorenal syndrome, their chance of being alive in 1 and 2 years is very low. It's between 20 and 50%. I never tell a patient when they're going to live or when they're going to die, but I give them percentage chances of something happening. Once people enter this hepatorenal syndrome, what we used to call type 1 HRS, we now call it HRS-AKI, hepatorenal syndrome, acute kidney injury. The chance of them being alive in 1 year is far less than 50%, and typically it's in the 20% range. So when we hear hepatorenal syndrome, we're going to be talking about short-term treatment with terlipressin, but we also need to be thinking about liver transplant. Is this patient a liver transplant candidate? We're going to be bringing in kidney doctors and talking to those kidney doctors about getting that patient on dialysis. Now, if a patient's terminal, they're not a transplant candidate, we typically don't go down the support pathway of dialysis because dialysis is also a bridge to transplant. Just like terlipressin is a bridge to transplant, it's a bridge to saving people's lives. Terlipressin decreases the time a patient's in the ICU and may prevent somebody from going into the ICU. It can decrease how long somebody is in the hospital. It can decrease the chance of coming back into the hospital. So this is really, I call it a magical medicine in the way that it manages not just the kidney, but it takes care of the whole patient and it prepares the patient for liver transplant. If the patient goes to liver transplant, they've had HRS in the pathway to liver transplant and they've gotten terlipressin, the chance of needing that patient needing a kidney transplant later is less. So that's important because that helps save resources. It decreases the amount of time they may be in the hospital after a liver transplant. It helps their kidneys recover after a liver transplant. So it's super important to be thinking about terlipressin for your patients, not just short term, not just keeping them out of the ICU or getting them out of the ICU and helping that patient recover for that next few weeks or few months, but also that pathway to liver transplant. Super important. Well, let's go back to the basics. What is ascites? Ascites is this fluid accumulation that you can see on this patient on the left in this diagram. That water around the belly is sitting there because water cannot make it through the liver, and that water is leaking and not being reabsorbed through the liver and through other blood vessel pathways. That ascites in and of itself, when you see this much ascites, not only a risk for hepatorenal syndrome, but maybe half of the patients in 1 year are alive when they have ascites like this. You see ascites, they need to be on the transplant list if they're a transplant candidate. And of course, thanks to Farah and other teams, we've had lots of discussion about transplant at these conferences. How do you select patients? How do you keep people alive until transplant? How do you take care of them after transplant? But this ascites is a huge warning sign and a major concern for that patient's chance of being alive, that chance of surviving long term. So what I'm going to do here is just show you a few of our medical diagrams and just think about other things we need to be concerned about. There's some other terms that are called compensation, decompensation, acute on chronic liver failure, symptoms versus asymptomatic. Well, what do we think about for symptoms? Well, is that fluid retention on their belly making them short of breath? Is it giving them pain? Are they having trouble ambulating? Are they having trouble eating? So we really have to think about the whole patient every time we're in clinic. We're going to be looking at their eyes. Are they jaundiced? We're going to be calculating a MELD score, MELD score, that's available through online calculators. We're going to calculate something called an ALBI score, an albumin bilirubin score, that helps a lot also with prognosis. We've talked about kidney dysfunction, measuring creatinine and change in creatinine. Talked about measuring blood pressure as a liver function test. We're talking about brain dysfunction, that's encephalopathy. Lung dysfunction, we're going to measure their oxygen status. Cardiac dysfunction, we're going to measure how their heart is working. We're going to do a physical exam. As you can see in this previous picture, that patient has had severe muscle wasting, a very fancy term we use now called sarcopenia, or frailty. Is that patient able to get up out of a chair on their own? What's their grip strength like? I shake hands with my patients with cirrhosis, not just to shake hands, but I can get an idea on their grip strength just with a simple handshake. So the liver is balancing all these different aspects of our body each day: nutrition, muscle mass, how our heart's working, how our kidneys working, and that's this hepatorenal syndrome, how our intestines are working. It's regulating blood sugar. The worse the liver gets, the more difficulty we have controlling diabetes. But also, we can have the opposite of diabetes. We can have a low blood sugar called hypoglycemia. That's why when people who have cirrhosis like this, trying to prevent progression, prevent this malnutrition, we're going to be giving them 5 to 6 snacks a day, high carbohydrate, low sodium, low fat, high protein. Super important. Now we're going down this pathway because creatinine, which we've talked about before, is super important. And I'm going to get to this now on this slide. Creatinine is a reflection, not just of kidney function, but the patient's overall nutritional status. We have in the past had a bias in our transplant system for men and against women because women have a smaller body size and lower muscle mass than men. So they've had a lower creatinine. Creatinine, as I mentioned, is a liver function test, and creatinine is part of the MELD score. So now we've recorrected the MELD score to MELD 3.0 to take into account what somebody's gender is. This has recorrected and brought women back towards a balance of getting access to organs because we're correcting for their lower muscle mass to give them a correct MELD score for their chance of survival or their chance of dying. Now I'm bringing this back up. This does have to do with hepatorenal syndrome because that's why we're here today. But when men and women get late stage liver disease, they lose muscle mass and their creatinine starts going down. So normal creatinine in a person who's healthy, no liver disease, ranges around 0.8 to 1. But now when you're missing all of this muscle, the creatinine might go down to 0.6 or 0.4. Back in the old days, we said, oh, hepatorenal syndrome, we don't have it till the creatinine is 1.5. Oh, we missed so many patients with hepatorenal syndrome in the past. So now we take their baseline creatinine, and let's say it's somebody with muscle wasting, who's got a small frame, a woman. Their creatinine baseline might be 0.4 or 0.6. That creatinine jumps by 0.3, from 0.6 to 0.9, or 0.4 to 0.7 in the setting of cirrhosis, in the setting of ascites. They have the signs of hepatorenal syndrome, and they need an intervention. The lower right-hand side of the slide is a bottle that's got albumin. We use albumin to boost volume, boost the circulation, boost kidney perfusion. Also, if somebody's really jaundiced, that can also falsely depress the creatinine. We need people to have good muscle mass, to have good creatinines. And that goes back again to what we talked about the cirrhosis diet. 6 snacks, high protein, high carb, low fat, low salt. This makes our assessment of creatinine, of kidney function, and hepatorenal syndrome much more accurate. The next slide is a table that we think about as doctors, as providers, our nurse practitioners, our PAs, our inpatient hospitalists, our gastrointestinal doctors that are in the hospital. And we look at small changes in creatinine to flag a major problem that's going on with that patient, with their kidney function. A 0.3 change in creatinine is indicating a major change in renal function, and it's time for interventions. You mentioned interventions. Make sure there's no GI bleeding, no infection, they're not on a toxic medicine, their blood pressure is good. We talked about giving some albumin, giving some volume, but within 24 hours, you're going to be making a decision. Do they have hepatorenal syndrome? And is it time to intervene with terlipressin? So down here on this little box, it talks about how much albumin to give people. I'm bringing up albumin here too, because if you overshoot with albumin, you give too much albumin, you can cause problems. You can cause respiratory distress. You can cause decreased oxygenation. You can cause what's called fluid on the lungs. This is an important issue because terlipressin also is active in the lungs and can also cause this leaky lung condition. In my experience, that leaky lung condition has been a problem only when you overshoot on the albumin, although in the package insert for terlipressin, it does talk about this risk of what's called pulmonary edema. So we have to monitor oxygen baseline. We need to monitor oxygen status when people are taking terlipressin. This slide just again talks about working up the kidneys, making sure they don't have chronic kidney disease. That's what we used to call HRS type 2. This is where you have acute kidney injury on top of chronic kidney disease. Every person that's in the hospital, you got to get a urinalysis, and somebody with cirrhosis, if there's any decompensation, make sure you've got a kidney ultrasound. Make sure the kidney are not obstructed in some way. There's something on here about sodium in the urine. I don't do that too often, but there are some academics who believe in that. So this makes it simple. Short period of time, serum creatinine is up by 0.3, 24 to 48 hours. It's time to be doing that intervention. I make a decision at 24 hours. I don't wait 48 hours to talk about that. This looks at HRS. This is in people with chronic kidney disease, but you also may wish to make that diagnosis of hepatorenal syndrome, even in people with chronic kidney disease, and be thinking about an intervention such as terlipressin. But if you wait too long or the patient has advanced chronic kidney disease, a medication like terlipressin is not going to work. Now, what this slide really highlights is close monitoring. Blood pressure, pulse, what we call volume status. Do they have edema? How's their oxygen? Is there fluid around their lungs? We're going to put that whole package together to talk about when to do the right interventions. Just the right amount of albumin, not too little, not too much. Just the right amount of volume. Maybe sodium chloride, some electrolyte supplementation. Not too little, not too much. So this is a balancing act that the inpatient team, ICU team, hospitalist team has to think about every day. I think we've talked about everything on this slide. This just talks again about these interactions between the liver, the kidney, the systemic blood pressure that's always there too. Now, you want that blood pressure, the upper number. You already heard 120 over 80 is normal, but you want that systolic blood pressure to be 90 to 100. And you get there, again, by giving the right volume, the right albumin. You want the serum sodium to be in the 130 range. If the sodium's down around 123, something's really wrong with that patient. You might have another endocrine disorder, and you may end up having to use some other medicines to increase blood pressure. Terlipressin does increase blood pressure. There's another medicine called norepinephrine that we also use sometimes in our patients. So wrapping this section up, I've got a lot of other technical slides a little bit later, but terlipressin is a synthetic hormone that's a variation on a hormone that we use in our body called vasopressin. Vaso for blood pressure, pressin for pressure. It has a selective affinity, or it likes to attach to these vasopressin 1 receptors that are found in the smooth muscle cells that are in the different arteries in different parts of the body. This is going to reduce how much blood flows coming into the intestines, into the liver, decreasing portal pressure, redistributing vascular volume, central circulation, and can open up the kidneys. So terlipressin can reverse that kidney injury, and that's what it shows on this slide. It can also change patient survival. So it's not just changing a kidney number, changing a lab number, it's changing where those patients sit. Farah, I'm going to go back to you now because we've really talked about this whole big picture, including our only medicine that's approved to treat hepatorenal syndrome. I'm going to stop share. I'm going to close that out. And I guess it's the way I stop sharing. I get that open.
Yes,
Let's go
thank
to
you
the
so much.
Q&A because we have about 20 minutes left.
Yes, thank you so much. You made a complicated disease very understandable for all of us. So that's very important thing for me to understand. I have the list of the questions people have asked, but I have a question for you since I'm a woman, and you talked about gender corrections regarding the transplant and what is difference between a woman's body and a man's body. Can you describe it a little bit more? And when this correction happens, does it cover all transplants or just liver transplant? And is it done all over the United States, or is it just in the specific centers?
The new MELD 3.0 takes into account gender for every person that's in the liver organ transplant system. I'm not going to speak about kidney, heart, lung, or pancreas here, but this is specific to liver, and this gender correction was a way to even the playing field between men and women, because women have a smaller body size than men and smaller muscle mass, and they tend to have lower creatinines, just as part of the natural laboratory assessment. This is also seen in patients with end-stage liver disease. So the new MELD 3.0 system is very fair to all patients. I think it's been a very good advance. It also includes albumin, although albumin can get a little bit messy because we're often giving people albumin, but it takes into account the baseline albumin before we started manipulating things by infusing more albumin.
Oh, thank you. One of the questions is, aside from cirrhosis, are there any other liver disease that can cause HRS, such as NASH?
You can't have HRS in a patient without cirrhosis. So all the causes of cirrhosis, that's the final pathway, could be NASH, alcohol, hepatitis B, hepatitis C, hemochromatosis. You know our list. You have to have cirrhosis. You have to have ascites to have HRS.
Please mention one more time the new names for type 1 HRS and type 2 HRS, and if kind of briefly touch on what you mentioned and the differences between these two.
So it's very simple. Does a patient have normal kidneys coming in, or do they have chronic kidney disease coming in? HRS type 1 is acute kidney injury, HRS-AKI. That's in people typically with normal or near normal kidneys. The HRS type 2 is an HRS you see in people with chronic kidney disease, And we need to have that difference because the chance of rescuing them with a medicine like terlipressin is less, and it's more likely that they're going to need a combined liver kidney transplant. That's a complicated subject to go down on how they distribute livers and kidneys together to patients. And there's some very specific criteria online. I think that's beyond the scope of this discussion today, but that can be maybe have another discussion, one of your other lectures.
One of the doctors who is an audience was asking, what are the criteria for liver transplant in patients with cirrhosis before they actually develop HRS? What do you look at?
So distributing organs is based on the MELD score. The MELD score is predominated, of course, by the patient's bilirubin and their INR, and more recently sodium. And now creatinine comes into play. The creatinine can go up without having hepatorenal syndrome. So there's other reasons that can go up, of course. Those all go into that MELD score, MELD 3.0, including gender and albumin. So organs are distributed by MELD 3.0, and that is a fair system. There's a lot of other discussions about how organs are distributed, but that calculation really levels the playing field.
And type 1 HRS ever be reduced to or changed to type 2 HRS?
After 6 weeks of type 1 HRS, the patient will have chronic kidney damage, and often after 6 to 8 weeks, that may be irreversible. And that's when we start discussing whether they need a combined liver kidney transplant.
And that's a very long transplant. We have a patient actually who speaks at our events who had a liver and kidney transplant. Very difficult recovery after that. Do blood vessels in the kidney narrow in a person with no liver issue? Or is just really just a byproduct of your liver disease?
There's other people who can have narrowing of the arteries that feed the kidney. They have a very special type of hypertension. It's an endovascular type hypertension. There's another special name for that. But that narrowing is not caused by the liver disease. It's caused by something else that's going wrong, probably genetics that change how the kidneys are perfused.
Very interesting. A lady had asked that her husband has HRS and or has cirrhosis, sorry, and her doctor has told her that there is a triggers that will change cirrhosis into HRS, and she's very concerned about the health of her husband and longevity of him, and he is under treatment for cirrhosis at this point.
And we talked about those triggers, Farah:
Yes.
infection, medications, low blood pressure, GI bleed. Those are all, part of that trigger. There's others as well, but those are the most common.
What is SBP?
SBP is an infection. It's a type of infection that occurs in the abdomen, in the ascites fluid. And that SBP can be a trigger for acute kidney injury. But remember, HRS-AKI is when you've ruled out infection, you've ruled out GI bleeding, you've ruled out hypotension. It's just part of a sign of that liver failing.
Please explain more how HRS may impact brain function. Is that HRS that brings it, or is that the liver disease that causes brain issues?
Yeah, it's the liver disease, the encephalopathy caused by liver failure that changes the brain function. HRS doesn't directly affect brain function, although if people are in complete renal failure, they can have some decreased brain function from what we call uremia. But that's not part of HRS. HRS does not directly affect brain function. Great question.
Okay, very good. I understand that the double transplant of liver kidney is a long and complicated surgery. I also have heard that HRS happens mostly in people that are in the last third of their life expectancy. Is that correct? And if that's correct, are there this assumption correct? Is that medically sound? And at what age will a patient not be qualified to have a double liver kidney transplantation because of cirrhosis and HRS?
We mentioned we're not going to go down the liver kidney transplant today because that's a very complicated, more than an hour discussion. There's no absolute age cutoff for liver transplants in general, although when people are over 70, we get very critical about their survival from other medical problems that they may have. And yes, it is a complicated pathway as people develop the combined liver and kidney, failure together. But I think the whole issue about dual transplant, you can have at a different meeting.
I know that this man has asked, please talk more about treatments. You have talked about the medication, and I know transplant is one of the treatments, but also the dialysis is one treatment. How long can a person be on dialysis before the kidney gives up? And is dialysis just a way of keeping the patient alive until the time is right for the transplantation?
Very, very complicated discussion. Dialysis does not treat the kidney disease. Dialysis treats the whole patient when the kidneys have failed. So we don't do dialysis until there's basically complete kidney failure. Although there are other reasons to do dialysis, such as people having too much water on their body, kidneys aren't working well. We can take the water off or maybe toxins off with dialysis. But dialysis is the late. And we don't say last third, we just say HRS, AKI is a late sign or a sign of very advanced liver disease. And when those patients are very close to dying and also very close to needing a liver transplant.
Yeah, unfortunately, yes. What is the role of electrolyte? You mentioned that in your speech in treatment of HRS, or what is its role with HRS?
There's no direct connection between electrolytes and HRS, but as in all patients, we want to keep the sodium around 130. We want to keep the potassium between 3.5 and 4.5. And of course, the rest of the electrolytes, such as chloride and acid-base balance, we want to be balancing those as well. But that doesn't directly influence the HRS issue. HRS is pretty simple once you've made that diagnosis. Patient needs to be listed for liver transplant. We need to use terlipressin. In some cases, we can reverse that HRS long-term, but those patients are going to be at risk of dying from a GI bleed or hepatic coma. There's other things that can occur in those patients with late-stage liver disease.
This is a long question, but asking, please comment on the following. Early detection is crucial in saving HRS patients' lives. Without therapy, a patient with liver disease, liver failure, will have an elevated chance of developing HRS. Most dies weeks after the onset of kidney failure. 50% of patients with liver failure and HRS die within 2 weeks. 80% die within 3 months of being diagnosed with HRS. Is that correct, comment?
Those are worse case scenarios in settings where there's no access to liver support or kidney support or advanced life support. I would say those numbers are relatively old and don't accurately reflect what's happening today at the transplant centers or hospitals that have advanced liver care. But I would take the next approach is that people who have HRS, AKI, that 50% would probably die within a year, but not 2 to 6 weeks. I mean, that would be hopeless. Then there's no reason for terlipressin, no reason to give albumin if everybody's going to die in that short a period of time. So it is a sign of advanced liver disease. It's a sign of a high risk of mortality. It's time to move to transplant. We try to reverse that HRS, keep the patient out of the hospital, getting to transplant, and also try to reverse their liver disease. Occasionally, we can reverse a liver disease and prevent another event of HRS, AKI by treating their hepatitis B or C, stopping alcohol, aggressively treating fatty liver, metabolic syndrome. Those are important ways to help manage our patients.
At the work in Orange County, we had a patient who had a very uplifting story. She was placed on transplant list because she had cirrhosis. And she went with medication, diet, completely stopped use of alcohol and all that. And eventually she has been moved out of taken off of the list of transplant. And she's very active. She hikes, she runs, she walks. And it's just, her story was very uplifting for people to know that even if you have cirrhosis, there may be life after cirrhosis. Yes. Okay, we have about 9 minutes. Would you like to share some more of your slides, or do you want me to get into my final comments?
I think we've covered everything quite well, Farah, keeping it simple in a very complicated environment. I think it's okay to wrap up this, and thanks a lot for having me today. Holly, thanks for your support from Mallinckrodt. Lori, thanks for helping to organize this. This is a very sophisticated, complicated subject area. I appreciate
Yes.
being invited.
Well, and you made it really easy to understand. Thank you so much for your wonderful presentation. Holly, if you are still there when you spoke, your camera was not on. If you can turn your camera on, maybe we can see you. I guess you can. Okay, so I want to thank Mallinckrodt and Holly Kirkpatrick for your support always, always. Now, June 12th is the Global Fatty Liver Day, which focuses on raising awareness about fatty liver disease. On June 12th, we will host an educational webinar to give more updated information about fatty liver disease. So please visit our website to register for that webinar. And that webinar is sponsored by Matt Briggle. Then on July 17th, we have another educational webinar on a rare liver disease, biliary atresia. We will have 1 or 2 biliary atresia patients in addition to our medical experts who will share their life story about living with biliary atresia. You will be able to register again by visiting our website. I also want to remind you of our in-person walk in September. Our annual Walk for Your Liver Los Angeles is on September 20th. It is not too late to register and be with us in support. Come with us, walk with us in Santa Monica in support of liver patients. Social media reminder, we are on all social medias. We have our own YouTube channel, so please visit us. Now, Memorial Day is on May 26th. Time to reflect on our country, its future, its past, and to honor American men and women who died while serving in the military. We are forever grateful to them and to those brave Americans who are serving now to protect our freedom. To our audience, thank you for attending this webinar. I hope you found it helpful with a lot of information. On behalf of Liver Health Foundation's staff, Medical Advisory Council members, and the Board of Directors, I thank our fabulous presenter, Dr. Robert Gish, for his dedication to liver patients and for participating in this webinar. Thank you, everyone. Good night. Stay safe and be well. Thank you.